CIDP stands for chronic inflammatory demyelinating polyneuropathy. One way of looking at it is a slow form of Guillain-Barré syndrome. It's commonly known within the neurologic community because it's one of the treatable causes of neuropathy. So the classic features of the syndrome is that people get symmetric proximal and distal weakness with some sensory disturbance. They frequently lose their reflexes, and the disease progresses or relapses greater than 8 weeks. Dr. Jeff Allen and I have a paper that will be in the Green Journal of Neurology, and that paper looks at what Dr. Allen did very carefully with 60 patients, referred to him with the diagnosis, and he found that over 50% of them did not have the diagnosis based on criteria. And my role in that was to basically look at the evaluations independently and blinded, and he and I agreed about the diagnosis in 59 out of 60 cases. And what was interesting about the study was that if you took the patients who had CIDP, about 3/4 of them felt that they responded to their treatments, whether they be IVIG, which was the most common treatment, or corticosteroids. But the most interesting feature was the fact that those who did not have the diagnosis based on our evaluations, 2/3 of them felt that they responded to the treatment. Well, there were a number of different disorders they had. A few of them had other immune-mediated neuropathies that are not considered CIDP, so that kind of misdiagnosis is not unreasonable. But many of them had pain syndromes, some of them had diabetic neuropathy, some of them had muscle diseases. So there was a variety of other disorders. Some of them just had joint pain, joint disorders, but they were diagnosed for various reasons. And one of the things we looked at is what were the factors that led to the misdiagnosis. Some of them was over-interpreting elevated spinal fluid proteins. Some of them, most of them, or many of them, were related to over-interpretation or misinterpretation of the EMG or electrodiagnostic studies. The other feature was people did not put the whole picture together. 95%, if not all, of the patients diagnosed with CIDP are diagnosed by neurologists. It would be there are some rheumatologists I'm aware of that sometimes make the diagnosis. But even for general neurologists, it's not a common disease. So my personal bias is, why not get a neuromuscular consultation before you start treatment? Or at the least, if your first treatment is not showing very significant objective signs of improvement, why not rethink the diagnosis and get a consultation at that?